Let's look now at abnormal labor. We've looked at the normal upper limits. Now we can define what is abnormal. Abnormal is basically when the duration of any stage or phase is prolonged over what it should be. Let's look at the first stage of labor. This is a labor curve showing different patients. First, we want to look at a nullipora. And you can see there's a sigmoid S-shaped curve. Notice the slope of that curve. This is a multipora. And notice how the dilation is much more rapid. 1.2 centimeters per hour, 1.5 centimeters per hour. And what if you have a gravida 8 para 7 grand multipora? Her labor can look like this, what we call precipitate labor. And this is a typical story in July. Intern checks his multipora. She's 5 centimeters and says, it's going to be a few hours before you deliver. Turns to walk out of the room. The patient says, I think the baby's coming. Intern says, no way, closes the door, and what's the next thing you hear? Wah! Baby's delivered. Okay, let's look at the various kinds of abnormal labor. We can have prolonged latent phase. We can have active phase arrest. We can have prolonged active phase, and we can have prolonged second stage. Let's start out with prolonged latent phase. 20-year-old gravida 1, 39 weeks, being observed in the maternity units. She states she's been having irregular uterine contractions for 24 hours, but cervical dilation remains at 1 to 2 centimeters. Vital signs are stable. Electronic fetal monitor tracing is reassuring regarding the fetus. So here we have a patient who is having contractions. Cervix is not changing. I think one could reasonably ask the question, is she even in labor? Is she having contractions? Because labor requires that there be some change in effacement and or dilation. In this case, she's not doing anything. Is this uncommon? No. Here we have the transition from the latent phase to the active phase in a normal labor curve. Here we have the transition from the latent phase to the active phase in a prolonged latent phase. So this is a prolongation. If it runs more than 14 to 20 hours, then we say it's prolonged latent phase. The most common latent phase abnormality is a prolonged latent phase. What's the diagnosis? First, we should identify that any time the cervix is less than 3 centimeters dilated, it is by definition in the latent phase. If the cervix is 4 centimeters or more dilated, it is by definition in the active phase. 3 to 4 is a transition, but if it's less than 3 centimeters, that's latent phase. And we already said that should be less than 20 hours in a prime, should be less than 14 hours in a multip. If it exceeds that, that is prolonged. What's the cause? Many patients come to me and they say, I had a cesarean delivery on my previous pregnancy, and I say, why did you have a cesarean? Because the baby was too big, she says. Well, how much did you dilate to? 1 centimeter. 1 centimeter? She had a cesarean in the latent phase. Do big babies cause problems in the latent phase? No. It's not because of excessively big babies. It is injudicious analgesia, hypotonic uterine contractions, or hypertonic uterine contractions. Injudicious analgesia. The patient is 1 to 2 centimeters dilated. Doctor, it's hurting so much. Can you please give me some medication? Why, sure. You give her medication, and what happens? The contractions poop out. Injudicious analgesia. Hypotonic contractions. Instead of being every 3 minutes, they're every 10 minutes. Hypertonic. They are frequent, they are intense, but they only last 20 seconds. Management, not cesarean. This is not a surgical management. Therapeutic rest, sedation. Give her some morphine, let her rest a little bit. Hopefully she'll wake up either in labor or the contractions will have gone away. All right, then we look at the active phase, and we can have either a prolonged or an arrested active phase. Prolonged is where it's dilating, but it's taken more than 1.2 or 1.5 centimeters per hour. An arrestive active phase is where it has stopped dilating completely. And here we have the arrest. A 20-year-old gravid 1 at 39 weeks gestation has progressed in labor to 8 centimeters. So she is definitely in the active phase, but she has had no cervical change for 3 hours. Is that normal? In the latent phase, that's fine. But in the active phase, there should be progressive change. Vital signs are stable. Electronic fetal monitor tracing is reassuring. What do we say about this? Here we have the labor curve. This is a prolonged active phase. You can see there is dilation, but it's going slower than it should be. And here we have an arrest. It went up to maybe 6, 7 centimeters and has stopped. All right, the diagnosis. The diagnosis is based upon cervix 3 or more centimeters dilated with either inadequate cervical change, which is less than 1.2, less than 1.5 centimeters per hour. That would be a prolonged active phase. Or if there's no cervical change for 2 or more hours, that is arrest of active phase. Now, where did we come up with the idea of 2 hours? This is based on observation of thousands of women in labor. If she doesn't change her cervix for half an hour, what's the likelihood that if you wait another half hour that she will? Very good. What if she doesn't change her cervix for 1 hour? What's the likelihood that she will change her cervix over the next half hour? Still good, but not as good as if it was just half an hour. What if she hasn't changed her cervix for an hour and a half? You see, you get diminishing returns by waiting. And at some point in time you say, gee, if it hasn't happened, it's not going to. We better find out what's going on. How long is that period of time? 2 hours. Certainly no more than 3 hours. So if there's no cervical change for 2 or more hours, we say that is arrest of active phase. The causes, these are what I call the 3 Ps. The passenger, the fetus. This is either because of the fetal size or the way the baby is oriented in the uterus. The mother's bony pelvis, or the powers, the uterine contractions. So the passenger, the pelvis, and the powers. Can you change the passenger? Well, of course not. Can you change the mother's bony pelvis? Of course not. The only one that you can change is the uterine contractions. How do you change the uterine contractions? IV oxytocin. So what we're going to do is to assess the quality of the contractions. They should be every 3 minutes. They should be lasting 45 to 60 seconds, and they should be 50 millimeters of mercury in intensity. Feel like your forehead. You cannot indent it. Give oxytocin if the contractions are hypotonic. If she's already having adequate contractions, there's no point giving oxytocin. Then you do a cesarean. So remember, the 3 Ps are the pelvis, the passenger, and the powers, and the only one that you can change is the powers. Oxytocin. All right, let's look at what we've just said. We want to identify first the phase of labor, and on the exam, the first thing you want to know if a patient is having contractions is what is her cervix. If her cervix is less than 3 centimeters, she is by definition in the latent phase. If she's 4 centimeters or more, she is by definition in the active phase. Prolongation of latent phase, multip taking more than 14 hours of primip, more than 20 hours. The management is ambulation sedation, not a cesarean. If you have a prolonged active phase, dilating at less than 1.5 centimeters an hour in a multip, less than 1.2 centimeters an hour in a prime, or if there is no cervical change for 2 to 3 hours, consider the pelvis, the passenger, and the powers. Of course, the only one you can change is the powers. Assess the contractions, the frequency, the duration, the intensity. If there are adequate contractions and no change, cesarean. If there are inadequate contractions, artificial rupture of membranes, IV oxytocin. Then you look to see, after IV oxytocin, have things changed? Is the cervix dilating at 1.5 or more centimeters per hour, 1.2 centimeters per hour? If it is, hands off, conservative management. If not, you're basically stuck with a cesarean. All right, prolonged second stage. Remember, the second stage is already fully dilated, and now it's pushing the baby out. A 20-year-old gravid 1 at 39 weeks has progressed in labor to 10 centimeters dilation. That's complete dilation. She's been pushing for 3 hours without descent of the head past +2 station. Now, I don't know whether she's got an epidural or not, and it really doesn't matter, because whether she does or not, 3 hours is too long. Vital signs are stable. Electronic fetal monitor tracing is okay. Diagnosis. Prolonged second stage is where there is failure to deliver the fetus, 2 or more hours without epidural, 3 or more hours with the epidural. The causes, the same as we looked at the first stage. Passenger pelvis powers. Can you change the passenger? No. Can you change the pelvis? No. But you can change the powers, and I would point out, in the second stage of labor, a difference from the first is the mother can now push. The only one you can change is the uterine contractions and the powers. Now, the pushing is significant. And the coaching of a woman in the second stage of labor is important. I've had patients who have a nurse that is sweet and kind. And this is how she conducts the second stage. Now, Mrs. Jones, are you ready to push? 1, 2, 3, 4. Now, what kind of motivation is that? I had a patient, she was 300 pounds. She had chorioamnionitis. She was pushing with a sweet nurse, and she wasn't bringing the baby down. And I didn't want to do a cesarean on her. I walked in the room, and here's what I did. All right, Mrs. Jones, are you ready? Start pushing. 1, 2, 3. Do you know what I'm talking about? A good coach can bring out a performance in an athlete greater than they ever thought they could ever do. And this woman pushed that baby out, no problem. Okay, second stage management. Assess the uterine contraction quality. If they are hypotonic, give oxytocin. If they're adequate, then you need to look at, is the head engaged? Is the head well down so you could use forceps or a vacuum extractor, do an operative vaginal delivery? If you can, great. If you can't, cesarean. You're basically stuck. All right, third stage of labor. This is now delivery of the placenta. 20-year-old gravida, 39 weeks gestation, underwent spontaneous vaginal delivery 40 minutes ago of a healthy 3,500-gram daughter. Everything looks fine, except the placenta still hasn't delivered. 40 minutes ago. Vital signs are stable. The upper limits of the third stage, we already talked about, is up to 30 minutes. The commonest abnormality of the third stage is prolongation. And the most common cause is inadequate uterine contractions. Remember, in order for the placenta to come out, the uterus must contract and shear off those anchoring villi. We can either look at medical or surgical management here. Medical management is IV oxytocin, and so we will typically use that. What if, in spite of adequate contractions of the uterus, and the uterus is firm, it still hasn't separated? In that case, you may need to go in with your hand and manually dissect between the uterine wall and the placenta and remove the placenta. Good pain relief is, of course, important here, because you don't want to do cruel and unusual punishment on this lady who's just had a baby. This figure shows the complications which can happen with a prolonged third stage. Hemorrhage, DNC, transfusion, and you can see things stay pretty good up until 30 minutes, and after 30 minutes, they really increase. And so we don't want to wait long, do a manual removal, and remove the placenta. All right, a few questions. 22-year-old woman at term has been 2 centimeters dilated for 3 hours, no change. And on all of these, there will be normal fetus on sono, cephalic presentation, normal electronic fetal monitor tracing. So I'm not going to read this. So she's 2 centimeters for 3 hours. Is there a problem? No. This is what you would expect. Observation, therapeutic rest, sedation. Don't mess with Mother Nature. Let's change the scenario just a little bit. She has gone from 4 to 7 centimeters. She's a gravida 1. She's gone from 4 to 7 centimeters over the past 2 hours with no change in station. What stage of labor is she in? Stage 1. What phase is she in? She's in the active phase. What is the normal progression in cervical dilation in the active phase for a prime? 1.2 centimeters per hour. She has dilated 1.5 centimeters per hour, so she's doing fine. Do you expect significant change in the station in the active phase? No, that primarily occurs in the second stage, management, observation. This baby, this mom is doing fine. All right, she's 6 centimeters dilated for 3 hours with no cervical change. Is there a problem? Now there is a problem, because we have a whole different set of expectations in the active phase than we have in the latent phase. She should certainly be dilating. So what we're going to have to do here is to assess what's the problem. And remember, we can't change the passenger. We cannot change the pelvis, but we can change the powers. Assess the contractions. She may need oxytocin. If the contractions are already okay, it may be a cesarean. Okay, here's a patient at term, regular contractions at 7 centimeters dilated. No presenting part can be palpated through the bulging membranes. You don't know if it's head down, if it's breech, if it's transverse. What's going on? How can you assess what's coming down first? Ultrasound. Let's get an ultrasound to identify the fetal lie, presentation. Maybe this is an abnormal fetus. Maybe there is some abnormality anatomically which prevents it from assuming the normal posture. This is a patient who's been 10 centimeters and pushing for 3 hours with no change in station. What stage is she in? Stage 2. What are the upper limits of normal for stage 2? Now we don't know if she's prime or multi, but in any event, she should have this baby out in 3 hours. The primary purpose of the second stage is descent, a change in station. There is clearly a problem here. Let's assess the quality of the contractions. If they're inadequate, give oxytocin. Otherwise, forceps, vacuum extractor. If that's unsafe, cesarean. This patient is 6 centimeters dilated, no presenting fetal part. You do get an ultrasound. It shows transverse lie. What if you rupture the membranes and there's no presenting part? This is important because this happens often in July with the new interns. Prolapsed umbilical cord, we'll talk about that later. Don't rupture the membranes unless the presenting part is well against the membranes. Signs of the third stage of labor. This was a board question. And there are 3 of them. Gushing of blood as the anchoring villi are removed. Lengthening of the umbilical cord as the placenta is moving down. And then you can feel as the uterus contracts, we call this the balling up of the uterus. So gush of blood, lengthening of the umbilical cord, balling up of the uterus. What are the factors that cause internal rotation of the fetal head? This was a question once. And what it is you have the uterine contractions which are pushing the head down, and as they meet the resistance of the levator ani muscles, it will follow the path of least resistance and rotate, and so you'll have the flexion of the head, internal rotation, the extension, and all of the things that we talked about. This is a test question that was on the exam. A student told me, define engagement of the fetal head. And the engagement is as the head comes down, descent, and the widest part of the head, which is the biparietal diameter, passes through the pelvic inlet and is now ready to move down through the mid-pelvis. So this is going to be with the biparietal diameter through the pelvic inlet, so the presenting part will typically be now at the mid-pelvis, which is 0 station. And that is the end of abnormal labor.